Assalamualaikum to our lecturer Dr. Ahmad Zulkarnain bin Ismail. Basically, today our group will present about the special test of shoulder injury. Before that, I would like to introduce our group member, which are Nur Najira binti Zamzuri, Muhammad Iyas Sajadi bin Muhammad Supri, Muhammad Faiz Aizat bin Muhammad, Sarah Nabaha binti Ismail, and me, myself, Muhammad Zulkarnain bin Razali. Without further ado, let's start. The function of shoulder special test. Shoulder special test help healthcare providers further pinpoint the precise cause of your pain, whether it be muscle or tendon problems, joint impingement or shoulder instability. The purpose of this test is to aid the diagnostic process and identify the most effective treatments.
Okay, my name is Muhammad Sajadi bin Muhammad Supri. So I'm gonna present to you about anatomy of shoulder. So surface of the shoulder, the shoulder joint, or we know as glenohumeral joint, is a ball and socket joint between the scapula and the humerus. It is a major joint connecting to upper limb to the trunk. Okay, so for the articulating surface or structure of the joint, the shoulder joint, glenohumeral joint, is formed by articulation of the head of the humerus with the glenoid cavity or fossa, we know as fossa of the scapula. This give rise to the alternate name for the shoulder joint, the glenohumeral joint. Like most synovial joint, the articulating surface are covered with hyaline cartilage. The head of humerus is much larger than the glenoid fossa, giving the joint a wide range of movement at the cause inherent instability to reduce the disproportion in surface. The glenoid fossa is deepened by fibrocartilage rim called the we call as the glenoid labrum. Okay, so next for the joint capsule in our shoulder, the joint capsule is a fibrous sheath which includes the structure of the joint. It extends the anatomical necks of the humerus to the border or rim of the glenoid fossa. The joint capsule is lax, permitting greater mobility, actually abduction. The synovial membranes lines the inner surface of the joint capsule and produce synovial fluid to reduce friction between the articular surface. To reduce friction in the shoulder joint, several synovial bursts are present. A burst is a synovial fluid fill sac which acts as a cushion between tendons and other joint structures. Okay, next we move to the burst in our shoulder. For the first burst is subacromial. It's located deep to the deltoid and acromion, and superficial to the supraspinatus tendon and joint capsule. The subacromial burst reduce friction beneath the deltoid and promoting free motion of the rotator cuff tendon Supracomial bursitis can be a cause of a shoulder pain. Next, the burst is subscapular. It's located between the subscapularis tendon and the scapula. It's reduce wear and tear on the tendon during movement at the shoulder joint. Okay, next we move to the slide. Ligament in our shoulder. So in our shoulder many of ligaments. So the first ligament is glenohumeral ligaments, which is the joint capsule is formed by this group of ligaments to connect the humerus to the glenoid fossa. They are the main source of stability for the shoulder, holding it in place and prevent it from dislocate anteriorly. They act to stabilize the anterior aspect of the joint. Next is coracohumeral ligaments. It attacks the base of the coracoid process to the greater tubercle of the humerus. It supports the superior part of the joint capsule. And last, transverse humeral ligaments, which is span the distance between the two tubercles of the humerus. It's whole tendon of the long head of the bicep in the intertubercular groove. Move to the slide. Cause and symptom of the shoulder can get pain. Shoulder pain may also be caused by arthritis in the shoulder joint, bone spurs in the shoulder area, and third, bursitis, which is inflammation of a fluid field set bursa that normally protect the joint and help to move smoothly. Fourth, broken shoulder bone. Next, dislocate of our shoulder. And next, shoulder separate. And next, frozen shoulder, which is occur when the muscle, tendon and ligaments inside the shoulder become stiff, making movement difficult and painful. Next, overuse or injury of nearby tendons such as bicep muscle of the arms. Next, tear of the rotator cuff tendon. And lastly, poor shoulder posture and mechanics. So that's all for cause and symptom. To the slide, common injury. Okay, for the common injury, I choose based on a special test, near test. I choose posterior shoulder dislocation, because posterior shoulder dislocation relate with rotator cuff strain and impingement.
Okay, so for the equipment that is needed for the special test is only the physiotherapy examination table or the physiotherapy treatment table. So that is all the equipment needed for a special test.
Next, do and don't. For section do, the first we must ask the patient to sit with correct position and tell the patient to tell the instructor when feel the pain. And lastly, patient must control their breathing. For the don't section, patient cannot do any movement when the test begin to avoid more injuries.
The drop arm test is used to assess for full thickness rotator cuff tear, particularly of the supraspinatus. This can be useful when diagnosing subacromial sprain syndrome or to differentiate between shoulder and rotator cuff pathologies. Now, I would like to explain about the anatomy of rotator cuff tear. Rotator cuff is a group of muscles and tendons that surround the shoulder joint, keeping the head of your upper arm bone firmly within the shallow socket of the shoulder. Rotator cuff tear occur when part of the rotator cuff is damaged that can result in pain, weakness and reduce the range of motion. There are 4 muscles and tendons that involve in rotator cuff. First is supraspinatus. The function is to hold your humerus in place and keep your upper arm stable. Number 2 is infraspinatus. The function is to let you rotate and extend your shoulder. Number 3 is teres minor. The function is to assist with rotation of arm away from the body. Number 4 is subscapularis. The function is to hold your upper arm bone to your shoulder blade and help to rotate the arm. For the mechanism of the injury, rotator cuff can occur in many ways. First, it can occur through repetitive overhead activity such as throwing a baseball, a tennis serve and a golf swing. Other than that, rotator cuff also can occur in a single traumatic incident such as falling on an outstretched arm by an unexpected force when pushing or pulling or during the shoulder dislocation. One of the special tests for shoulder test is drop arm test. First, turn behind or beside the patient and passively lift the patient arm to 90-degree position and full external rotation while supporting the arm at the patient's elbow. After that, ask the patient to hold the arm position and release the elbow support. Ask the patient to slowly lower the arm back to natural. The test will be positive if sudden dropping of the arm or weakness in maintaining arm position during the eccentric part of abduction.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Faiz Aizat Muhammad, and today I'll be explaining briefly on the AC joint sprain. So, the AC, or the acromioclavicular joint, is formed where a portion of the scapula and the clavicle meet and are held together by tough tissues that act like tethers to keep the bones in place. It is commonly the result of a direct fall onto the shoulder that injures the ligaments that surround and stabilize the AC joint. If the force is severe enough, the ligaments attaching to the underside of the clavicle are torn, causing separation of the collarbone and wing bone. The scapula moves downward from the weight of the arm, creating a bump or bulge above the shoulder. Okay, so moving on is the levels of the AC joint injuries. So type 1 is where the ligaments are stretched, and type 2 is the partial rupture of the AC ligaments. For type 3 is the complete rupture on the AC and the CC ligaments. For type 4 is the clavicle displaced posterior over acromion. For type 5 is the clavicle displaced just under the skin. And for type 6 is the clavicle underneath coracoid. And for type 6, it is very rare and it doesn't happen frequently. Moving on, I'll be explaining on the special test that I chose, which is the resisted AC joint extension test. So the purpose of this test is that to help identify the acromioclavicular joint pathology in both traumatic and non-traumatic cases, and it can be useful in helping differentiate between AC joint and impingement syndromes. So I'll be explaining a little bit on the technique. And the first one is the patient has to be seated with the therapist standing behind him. And the second is the patient's shoulders is positioned into 90 flexion and internal rotation with a place into 90 flexion. The third step is the therapist place his hand or her on the patient's elbow and ask him to horizontally abduct the arm against isometric resistance. And the last step is a positive test, is pain at the AC joint. So next, I'll be demonstrating on how this technique is executed. Warahmatullahi wabarakatuh. My name is Muhammad and today I'll be showing on how to do the special test for resistor AC joint. Okay, so first of all, the therapist should place himself behind the patient, and first you lift up the elbow to 90 flexion, and then rotate the elbow internally into 90 flexion also, like this. Okay, and then the third step is that you abduct the arm like this horizontally against an isometric resistance, like this. Okay, so a positive test is when the AC joints feels painful. So that is all. Thank you.
Stand on the affected side, then place one heel of the hand on the scapular spine and the heel of the other hand against the clavicle. Cup the hands over the shoulder, then squeeze the heels of both hands together. A positive test will result in abnormal AC joint movement and pain provocation. This is the top view when doing the special test.
Next, we move to mechanism of injuries. So, posterior shoulder dislocation have been linked to epileptic convulsions, high energy trauma, allotraction, and electroconvulsive therapy, or we know as ECT. Posterior dislocation is accompanied by a fracture of the necks of humerus or fracture of the tuberosities. Next is the injury is caused by a fall onto an outstretched, internally rotated arm. The force of the impact forced the humerus head posteriorly out of the glenoid cavity. Special test, knee test. Okay, for anatomy of a knee test, the knee test, flexing the shoulder and applying pressure to simulate the symptom of rotator cuff impingement. So rotator cuff impingement ni occur after shoulder dislocation, anterior shoulder dislocation and posterior shoulder dislocation. If there is an issue with the supraspinatus or bicep brachialis, the symptom should be reproduced. When performing the knee test, the elbow should be extended, the humerus in internal rotation, and the forearm pronate. When the examiner passively flex the arm forward, it compresses the structure between the greater tuberosity, inferior acromion process, and acromioclavicular joint. So that's for anatomy of knee test. Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Sajidi bin Muhammad Supri, and I'm from RSR2454B. So today I'm gonna present you a special test about shoulder. So my injury is shoulder dislocation and rotator cuff strain. So the special test for the injury is knee test. So how to do a knee test? The step first is put your hand on the scapula to stabilize. Next, other hand, hold the arms of patient and pronate and up the arms maximally until the patient feel pain. So the first step, use your hand to put on the scapula to stabilize the scapula, and other hand, before that, your patient must straight the hand, and other hand hold this arm and pronate the arm and up the arm maximally until the patient feel the pain. Okay.
The patient should be positioned in supine. The therapist will flex the patient elbow to 90 degrees and abduct the patient shoulder to 90 degrees, maintaining natural rotation. The examiner then slowly apply an extension rotation force to the arm to 90 degrees, while carefully monitoring the patient. Patient apprehension from this maneuver not pain is considered a positive test. Thank you.